My name is WonJae Lee from Seoul National University Bundang Hospital. I'm an interventional cardiologist, and it's my honor to be here today. I'm going to talk about recent update on DAPT strategy for PCI patients. I have nothing to disclose. So I'll start with short DAPT strategy for high bleeding risk and move on to DAPT for high ischemic risk. And I'll introduce some of recent trials with new P2Y12 inhibitors. So more patients are at high bleeding risk for bleeding nowadays. They are older, they have a CKD, patients are long-term NSAID use, they're undergoing non-cardiac surgeries, and patients have atrial fibrillation who are using DOAC. AHA made a definition for high bleeding risk, and you can see that some of the features I just introduced, and in addition, their liver disease, active cancer, anemia, low platelet count. And these patients make up actually 40% of all the PCI patients we are doing right now. We all know that mortality after occurrence of bleeding is very high, and in these cases, shorter DAPT is actually associated with lower risk of death. So there has been many short DAPT trials starting 2019 and continuing on. Actually, there was a TICO trial, host-rigid polytech trial, which was scheduled to end in 2023, was actually published in 2020, and I'm going to introduce them later on. So this is one of the landmark studies which studied safety of 3 months DAPT for PCI patient. Patients were all comers, and 32% had ACS. And there was giants using a strategy and DAPT for 3 months. So what we saw is that the only event rate was less than 3%, which is much lower than expected event of 6.6. And more importantly, at 1 year follow, there was no definite or probable thrombosis, even if we had a 3 months DAPT strategy. And there was a smart choice trial, which was done in Korea. Also all-comers trial, and among them, ACS was about 58%. The trial was using various types of secondary stents, and that for 3 months versus 12 months. And as you can see that there was no difference in composite of events during this 12 months. And as expected, if we use longer DAPT, there is more event with bleedings. And there was STOPDAPT trial, which evaluated safety of 1 month DAPT. It was also all-comer trial, and 38% of patients were ACS. And as you can see that in this case as well, there was no difference of composite outcomes whether patients are 1 month DAPT or 12 month DAPT. And of course, if patients are on 12 month DAPT, they have more risk of bleeding. I just want to note one thing. All the patients actually had a IVUS examination, which actually optimized all the PCI procedures. However, I think we still have situations that we need for prolonged DAPT or more potent antiplatelet agent. ACS, heavy calcification, left main disease, bifurcation, patient's diabetes. Can we actually still just use 1 month DAPT? So there was a trial called SMART-DATE, which was also done in Korea, and it looked at safety of 6 month DAPT in ACS. 100% ACS and 70% was MI. So basically evaluating 6 month DAPT strategy versus 12 month. Although there was no difference in MACE, but if you look at only MI, there was definitely difference. After 6 months, there was actually more increase in event of MI, which tells us that maybe for very high risk patient, 6 months or shorter DAPT strategy may be dangerous to patient. And there was ideal left main, which evaluated 4 month DAPT strategy. Well, this trial have some controversy because it was evaluating, comparing synergy and giants at the same time, 4 month DAPT strategy with 12 month DAPT strategy. If we look at the result, well, there was no stent thrombosis between 4 and 12 months. However, with synergy stent, there was a couple of 4 events with definite or probable stent thrombosis, so which give us still some concern that in left main disease, maybe shorter DAPT may be dangerous to patient. There was meta-analysis having evaluating duration of DAPT after complex PCI. There was a patient-level pool analysis and optimized, excellent, produced all the trials that you all know. And components complex PCI were 3 beds treated or more than 3 stents, bifurcation or very long lesion, or CTOs were included. As expected, people who underwent complex PCI had much more event. It was more than twice, but there was no difference in bleeding. And what are high-risk procedure subset? Well, all of them have a higher risk, but among them, 2-stent strategy at bifurcation had highest risk for ischemic risk. So, in these patients who are undergoing high complex PCI, so if patient have no features complex PCI, 12 DAPTs or 6 DAPT, it doesn't really matter. However, if patient have 1 or 2 or even more features for ischemic complex PCI features, definitely 12 months DAPT strategy favors patient. This is also a COBIS registry, which is a coronary bifurcation stenting registry in Korea. And in this study, we evaluated DAPT more than 12 months and less than 12 months. And you could the result, if patients were under 12-month DAPT strategy, you can clearly see that after 1 or 2 years, there may many more events happening, cardiac death, MI, or stent thrombosis. Again, telling us that if patient underwent bifurcation with a 2-stent strategy, maybe patient might need more prolonged DAPT. And this is result of Grand DES registry, which evaluate left main bifurcation. So patient was divided to 2 groups who had underwent left main bifurcation PCI, 1 stent strategy and 2 stent strategy. If you look at the result, if we use DAPT for more than 1 year, it doesn't really matter patient had 1 stent or 2 stent. However, if patients are under DAPT for 12 months, there's significant difference between 2 groups. So patient had 2 stent, and if they had a less than 1 year of that, there is significant increase in target failure or thrombotic-related adverse cardiac events. Now I'm going to move on to clinical trials with new P2Y12 inhibitors. So there was a trial, with TWILIGHT trial, which evaluated high-risk PCI patient using giant stent, and it was comparing 3 months DAPT versus 15 months DAPT, and actually was comparing ticagrelor single strategy with ticagrelor plus aspirin. If you look at the baseline demographics, patients were about 65 years old. There was about 35% of diabetes patient, and CK 16%, and ACS presentation was 64, which was quite high. And multi-vest CAD was 63%, and total length was 40 millimeter, which was also a high-risk feature. So if you look at the primary endpoint, which was BARC 2, 3, or 5 bleeding, yes, there's significant difference between ticagrelor aspirin versus ticagrelor alone. Yet, however, even if patient on just ticagrelor single compared to ticagrelor plus aspirin, there was actually no difference in death, MI, or stroke, which is telling us that with newer, stronger agent, we might have a shorter DAPT duration, but still managing ischemic risk. Recently, it was, I think last year, there was 2 landmark studies for different strategies for P2Y12 inhibitors were introduced. One is TICO trial, which evaluated ticagrelor monotherapy versus ticagrelor plus aspirin in Korean ACS patients. So what was done was that patient was on that for 3 months, ticagrelor plus aspirin, and then after 3 months, one group maintained this DAPT strategy, but one group dropped aspirin and maintained only ticagrelor. So if you look at the left side, 12-month clinical outcome, there was actually significant difference between longer DAPT versus shorter DAPT. And of course, after 3 months landmark analysis, there was significant difference. Where the difference coming from? So primary endpoint was actually composite of MACE and TIMI major bleeding. So the major difference was coming from actually bleeding. If you look at the left side, there was 87 risk reduction if we use shorter DAPT in major bleeding. However, there was actually no difference in ischemic endpoint, and there was no significant difference in statistically. However, you look at it, there was actually numerically more events with 12 months DAPT strategy versus 3-month DAPT strategy. And this result was reflected in ESC guideline in 2020. So if you look at the non-ST elevation ACS patient, if patient have a low risk of bleeding, patient can have aspirin and ticagrelor for 3 months and move on to ticagrelor single strategy. Next is that procedural-based de-escalation of DAPT after PCI, which is called host-reduced polytech ACS trial, also done in Korea. So there was a two group. Procedural 10 mg was maintained for 1 month, and after 1 month, one group was randomized and de-escalated to procedural 5 mg. And the other group was procedural 10 mg throughout the year. And the result was that this study also looked at NACE, which is net adverse clinical event. And as expected, there were much more events with conventional strategy compared to de-escalation strategy. De-escalation strategy had only 7.2% event, whereas conventional had a 10.1%. And key secondary outcome, which was efficacy outcome, look at it, there's no difference. And again, numerically, de-escalation strategy actually had a less event compared to conventional strategy. And of course, if we look at the safety outcome only, there was significant difference between de-escalation versus conventional, which had a 10 mg throughout the year. And there was one more group, which was observational, since procedural had indication, does not have indication for people older than 75. And it seems that there was much more event in observational group as well, telling us that we might need to have a new strategy for these patient subset using this kind of new P2Y12 inhibitor as well. So my take-home messages are, we should now definitely apply shorter DAPT strategy for patients with high bleeding risk. And to do that, we have to simplify PCI and minimize matter burden for these patients if they have high bleeding risk features. And of course, there are still patient subset who has high escape features that still mandates longer DAPT. And shorter DAPT duration or de-escalating strategy with new P2Y12 inhibitors might give us some solution to mitigate these kind of patient who has high risk at the same time with high bleeding risk. Thank you for your attention.